Hello, and welcome to Workforce Wisdom. I'm your host, Christy Bray, Chief Strategy Officer at PracticeLink. This podcast focuses on the latest trends in healthcare recruitment while showcasing innovative strategies, success stories, and fresh perspectives affecting the healthcare workforce. These episodes will lead to in-depth, thoughtful discussions with recognized industry-leading healthcare professionals exploring the challenges of healthcare recruitment and beyond. Whether you're an experienced recruitment professional or just starting out, this podcast aims to help you discover how experts are reshaping the industry, leveraging technology, and fostering inclusive hiring practices. Today's episode of Workforce Wisdom, Recruiting Beyond City Limits, a rural health conversation with 3RNet's Mike Shimmens. Welcome, Mike.
Thank you very much, Christy. It's great being here with you.
Nice to have you. For our listeners, Mike is the Executive Director of 3RNet, a national nonprofit organization dedicated to improving access to quality healthcare in rural and underserved communities by supporting the recruitment and retention of healthcare professionals. Since 2012, Mike has led 3RNet in collaboration with a 9-member board of directors and a staff of 4, overseeing a network of 54 member organizations across the U.S. With more than 20 years of experience in healthcare recruitment, Mike previously directed recruitment and workforce development efforts at the Missouri Primary Care Association and began his career in physician and advanced practice nurse recruitment at St. Mary's Health Center in Jefferson City, Missouri. A long-standing Association for Advancing Physician and Provider Recruitment member, Mike holds the Certified Physician Provider Recruitment Professional credential, a bachelor's degree from Missouri State University, and a master's degree from Western Illinois University. So, Mike, tell us a little bit about your career path and what led you to your current role at 3RNet.
Yeah, I think like many people, my career path was not straight into healthcare. I actually have a marketing degree and had a couple different careers before I got into healthcare. I worked at 2 different universities in the St. Louis area. I actually did event marketing also earlier in my career. So coming into healthcare was not what I was expecting, but I got into healthcare as an in-house physician recruiter because I was coming back to my hometown of Jefferson City, Missouri, and it was a job that was available. I knew my hometown. I knew nothing about healthcare, but it was a nice fit because I had the marketing background. So I kind of got into it from there. I served 9 years recruiting physicians to both our Jefferson City, which is a town of about 50,000 people, but also some of our rural communities where there were clinics and things. So that's kind of where I first started getting my taste for rural. I moved over to the Missouri Primary Care Association, where I worked primarily with community health centers in the state of Missouri, but also some other smaller employers, critical access hospitals and rural health clinics. And in that role, I became the member for our organization, 3RNet, the National Rural Recruitment and Retention Network. So as the Missouri member or network coordinator, as we now call them, I had a lot of experience with 3RNet. I actually joined the board of directors while I was in that role for 6 years. And basically, when our previous executive director, Tim Skinner, left, I was there on the board, ready to go, and it worked out very well. So that's how I kind of got to where I am, always kind of in recruiting, but I haven't done the direct recruiting as much since, probably in these last 12 years. But we work with all the states. We have members in every state, so a lot of experience there.
Yeah, I actually remember the Tim Skinner days, so I'm glad you put some context around the names and then your career path.
Very well-known name in the AAPPR world as one of their founding people.
So it sounds like, those early experiences in that hospital or that community-based recruitment really shaped your approach. And serving a town, 45,000 sounds small if you live in LA, maybe if you live in the Dallas-Fort Worth Metroplex. So would you consider that rural, or how did that kind of shape your approach to assisting rural and underserved areas?
Well, I think it was certainly smaller. Again, we were part of SSM Healthcare out of St. Louis. So it was a 167-bed hospital. So it was pretty full service. And it's a 2-hospital town here in Jefferson City. So we have the University of Missouri also is a large player. So it felt pretty big as far as a market is concerned. But I think it was those rural clinics and having to recruit to, at that time, I want to say we had like 7 or 8 rural clinics. And some of these were in towns of 1,000, 1,200. And so having to go there, meet with the communities, meet with the staff, trying to find somebody that's a decent fit for these communities was challenging for sure. I had some successes, certainly had some failures, but I learned a lot in doing that. So I think not being from a large metro area too, even though I'd lived in St. Louis and come back from St. Louis to Jefferson City, I felt a lot more at home in a community this size. So I think I can translate a lot of different environments into the work that we do.
Yeah. I think over the years, we've talked about the U.S. Census Bureau defines rural as a town under 50,000. And I think for me, as I recruited to some small places and then also some medium-sized places, but they were far from something. So for me, rural isn't necessarily the population size. It's how far away are you from maybe an airport or the important things like Starbucks. So that's where I think I have a little bit different definition. When you get to the 5,000, 1,000 populations, it gets pretty tight in what the offerings are in a community.
For sure. And I think that definitely affects everything that you look at when you're trying to recruit to a rural community. Proximity to a larger city is probably one of always the most indicative things, or one of the things you really need to look at. But again, everybody's version of proximity is different too. For some people, half hour is way too far. For others, an hour, half, two. I mean, I drive to the airport in St. Louis. It's an hour and 45 minutes away. We have an airport, a small airport in Columbia, Missouri, only 20 minutes, but it's got very few commercial flights. So in this area of Missouri, central Missouri, we get used to going either to Kansas City or St. Louis for an airport. And some people, that would be just not possible. That's just not going to be convenient at all. But for us, it's like, well, it works. You have to take that with the low cost of living. We have wonderful housing prices here in this market. It's a very pretty town, historic. So there's a lot of benefits as well. So yeah, everybody's version of kind of how far am I from what my activities are is different. Because again, if you like the outdoors, you're a lot more in it. And some people, they would drive 2 hours to the mountains, but other people want to live in the mountains. So it's just your perception for sure.
Yeah, absolutely. And I know we'll get into a little bit more about some of those challenges and trends in rural recruitment. Tell me a little bit about, or what are some of your guiding principles supporting those rural and underserved communities, kind of, especially as you've been at 3RNet for 12 years and the growth that organization has had, but what's kind of guided that work along with probably the support of your board and those other folks you have?
I think the biggest thing is the approach to rural recruitment is every community is unique. And a lot of people talk about this, so I'm not going to, relay some of the old standard kind of phrases, but every community has benefits. Every community has challenges they have to overcome, regardless of size. That's from the very largest to the very smallest. In a small area, you have to really work hard, though, to pull together a team of people that can help you present your case for why you want to live there. And that's probably the biggest guiding principle I've had, is that in a larger community, a single recruiter at a hospital can get a lot of access to resources around them that can help them. In a smaller community, you're going to have to do it as a team. So I've always believed, and I think that 3RNet has always been a big proponent of, what is your team that's going to do this work in a rural area? Because it's really all hands on deck, including your community. That's your Chamber of Commerce, that's your school board. When you're trying to bring somebody into a community that's, let's say, 1,500 people, everybody has to have a part in it. And so I think that team-based approach is very important, and it's something that I've always wanted to stress in everything that we do at 3RNet. We definitely promote that all the time. And you have to be creative with it. I think at one point we were doing a presentation called It's Both an Art and a Science. There is some science to this. AAPPR is a great example of somebody that over the years, they put a lot of materials out there. You can follow, there's books and a lot of procedures, and that's wonderful. But it doesn't fit into every situation. It doesn't fit into many small communities. You have to be able to adapt the best practices into your small environment. And that's what I feel like 3RNet does, and I feel like that's our role.
Yeah, I would agree with all those points. I think that you do find those folks in the smaller organizations that, you're wearing many hats beyond the other duties as assigned. You end up with a lot of places to fill. I think it does give you a unique opportunity to showcase and really provide that high touch of a site visit, still rolling out the red carpet, and really create some unique experiences for the candidates who visit, for sure.
Yeah, in a small community, and I say, you can't look at the roles of the people at your organization either, because you may have somebody that's working in your cafeteria that's your school board president. You might have the mayor working for you in radiology, and it's like, well, you've got to kind of think of all your community assets that are working for you that can pull together. And it's not just the HR department or not just your CEO. It's really everybody that's on your staff, and you got to think creatively and bring them into the process and as that welcome wagon. And then, like you said, your outside external partners as well. Who do you know? So as you know, in a small community, word travels fast. So you have to engage all those resources.
So for those not familiar with 3RNet, can you describe a little bit about what the company's doing or the nonprofit is doing and who it serves, maybe those 54 organizations, et cetera? Could you explain that a little bit?
Yeah, so we have a 30-year history. 3RNet was actually founded in 1995, and as a nonprofit, many of our organizational members of those 54 organizational members are state offices of rural health. Every state has a state office of rural health, and they direct activities for a lot of rural health access in each state, workforce being one of them, and we are a product then that can assist them with that. We also have some members that are very well versed, like a primary care office in a state, a primary care association. A lot of those work with the community health centers. I always try to think of it in terms of the employers that we work with. Work with a lot of federally qualified health centers or community health centers, the critical access hospitals, the rural health clinics, IHS facilities, Indian Health Service facilities, Veterans Affairs facilities, other nonprofit organization, anywhere where you see a safety net provider. That's what we're trying to be of assistance to. We're trying to do a little bit more in behavioral health, for example. So that's kind of the market that we work with. These 54 organizational members are how we kind of get the message out in such a small staff to the entire country, because they are our workforce. They do the boots on the ground work in each and every state or organization they're in. We have a couple of members that are not state affiliated. One is Cherokee Nation. The other is Commonwealth of Northern Mariana Islands. And then, as I mentioned, both Indian Health Services and VA. So I really think about the employer types and how that we as organizations, members, try to reach out to them and bring as many under the umbrella as possible. And again, I think the most noticeable activity that we do is, of course, our job board. And that has been there since the mid-90s when job boards weren't even out there. We were still, getting that up and going. Our founder, Fred Moskal, was the director of the State Office of Rural Health in Wisconsin. And so that activity has carried through with us to today. And so we do a lot of our work through our organizational members, and then that person in each state that we call a network coordinator, they direct the activities of how to use 3RNet. And we've expanded a lot. We do a lot more educational activities now. We do other services as well. So we try to keep in mind who that end user, who that end community or safety net employer is that really needs our services.
Yeah. And so your support then, so most of the program coordination is done at the state level, probably relying on state funding then.
Yes, the state offices of rural health especially are funded both by state dollars and some federal money through the Federal Office of Rural Health Policy.
Okay. And then that support translates over into the hospitals or health systems. They may be county owned. They may be owned by a larger national health system, but it's probably a really good mix there of what you're looking at.
Yeah, there is definitely a kind of a whole hodgepodge of different types of ownership arrangements, right? Some of them are large systems. You can find rural health clinics in large health systems. You can find them independent standalones that are actually run by a nurse practitioner. And also depending on the state, how many services they can provide. Okay. So it's very different, but I think that we try to stay really in the lane of the critical access hospitals because they are so tied to the Federal Office of Rural Health Policy, rural health clinics for sure, the federally qualified health centers or rural health or community health centers. Those are probably the three biggest ones. And as I said, we're trying to do a little bit more with behavioral health, obviously IHS and VA as well because of those relationships. So those are kind of the main employer types that we work with, but we do not make it exclusive. Really, it depends on our state organizational member, on the communities and the types of employers they work with. We set up the structure at 3RNet. They implement the structure in their state and how it works, however they wanted to make it incorporated.
That seems like a great way to kind of deploy the resources across the country in many of those areas where just staffing can be difficult to find somebody to manage some of that. Can you give our listeners a couple of definitions? So critical access hospital defined as?
Critical access hospital, it is a designation primarily given out, I think, through Medicare. And there's 12 or 1,400 of them in the country. So basically, yes, a smaller hospital that definitely is serving a certain population. And for that, they get a little additional reimbursement. Rural health clinics are similar, only they're not inpatient. Those are just a clinic environment. And they can be owned by a system. They can be privately run, but they also get a little bit higher reimbursement from CMS.
And then a federally qualified?
Federally qualified health center or community health center is, so when I worked in Missouri Primary Care Association, that was our primary interest there. They're a little bit unique in how they are arranged. They get some additional federal grant funding. They have a board of directors that has to be 51% patients of the clinic. And they also provide primary care only in an outpatient setting, dentistry, and also a lot of them provide behavioral health. They also have a sliding fee schedule. Anybody can go to a community health center and be seen. So it's a little bit different in that regards as well. Now, a lot of critical access hospitals and rural health clinics are also seeing a lot of the uninsured or underinsured. Federally qualified health centers have to. The extra reimbursement they get through grant funding is to go toward that. So they have a sliding fee schedule that can help determine how much a person has to pay when they visit an FQHC.
Yeah, thanks for that. I know working through those, and there's different pieces, for the physicians listening, all those things make a difference sometimes in potentially grants or scholarships or funding that they may have received during their training, equally the type of setting and the population they want to serve in their career. Looking at a HPSA score, we probably have to define that. So a HPSA score, along with the MUA, medically underserved area, all of those scores probably add up, and that would give you a really good example of who 3RNet is serving in the country.
Yeah, I think the office in most states that works with HPSA scores and MUAs and all this kind of activity is typically called a primary care office. The majority of primary care offices are through a state Department of Health. They do not have to be exclusively. So you need to find out within your own state who your primary care office is and where they are located. And that is a very important person to know. Oftentimes they know about 3RNet or actually are a member or in the same office as our member. And that's why we sit side by side with the State Office of Rural Health, a primary care office, and then 3RNet are all kind of in this workforce space trying to direct activity for especially clinicians that are wanting to work in that space, right? Because they are important. If you happen to be looking for loan repayment, whether at the federal or state level, or if you're wanting to just work with a population that is underserved, you certainly want to keep all these different employer types that I talked about are the ones that are going to be high on your radar screen. We actually have a guide on our website that directs traffic and explains some of these even better because that's kind of, I think, one of the biggest part of our mission as far as reaching out to clinicians, whether it be physicians, or again, we work with all clinicians. We want them to know, here's the different types of facilities you can look into. Here's some questions you may need to have. And certainly you'll always need to kind of know if you're looking for loan repayment or some other kind of grant program, what's the HPSA score and that kind of thing. So we're hoping, in our best efforts, 3RNet helps make a one-stop shop in a state. You can call our coordinator in that state, ask some questions, and if they don't know the answer, they can hopefully direct you to traffic to somebody else that can answer a question for you, whether it's on a HPSA score or an MUA, or how many FQHCs do you have in your state, or how many critical access hospitals do you have, if any, those kinds of questions. So you kind of get to know that person. So if you're in a job search and considering that kind of work, I definitely think we're one of the resources you want to have high on your list to check anywhere.
Appreciate giving those definitions.
It's taken me years to get to this point, trust me, and I still do not do great at it. So I totally understand. And that's why we're here. We are there to answer the questions, and nobody's asking a dumb question. There's way too many acronyms, and you have healthcare acronyms, and you got rural acronyms and government acronyms, and we can help you navigate it.
You mentioned that you do serve a larger clinician population than PracticeLink. I know you have licensed clinical social work positions on your board and other things. So I'm going to ask a question about trends, but I want you to answer it in kind of the all clinician that you're seeing. But, what significant trends are you currently seeing in rural workforce development expanded beyond the traditional scope of PracticeLink as physicians and advanced practice providers? So expand that in your 3RNet world.
Well, I think the trends, it's always been difficult to recruit, obviously, kind of all health professions. And it's really interesting, though, that in some states, a hard to recruit position may not be that hard in the next state. And it really kind of depends on your pipeline. For example, some states have a real hard time with lab techs. Even MAs, medical assistants, can be a very big challenge in some states. In other states, because they have maybe a better school pipeline, they are doing better in that area. I do think that we have seen, as far as a trend, post-COVID, the increase in behavioral health need is universal across every type of community, especially small communities. Need for that. And that's not just your social worker, right? That's still one of the core types of professions you're looking for, but you're also looking for even any kind of tech, behavioral health techs, psychologists, really pretty much the whole gamut of behavioral health. So I think that that has certainly grown. The other needs have not gone away. Nursing was all over the place, as nursing often is, unfortunately, because nursing can be either feast or famine. It's rarely feast, but sometimes you do get a surplus. But since, again, post-COVID, that has still been a big challenge that many states and communities struggle with. I do think that it is interesting from just the little data that we collect from 3RNet and our website. We actually were getting a lot more jobs in the last few years post-COVID, a lot more activity recruiting, and the candidate flow across all professions had slowed down. Our physician candidate flow, quite honestly, usually stays very stable because we have physicians graduating all the time, right? And it's pretty stable on the ones that are graduating. So that level stays pretty good. It's the others that have gone up and down, the auxiliary professions, and that had gone way down after COVID, but it is definitely coming back up now. We are seeing a lot more candidates coming in. I don't know if the past 4 months and everything that's happened for the past 4 or 5 months of the change of administration, if that has had an effect. It was going up already. And certainly we've seen layoffs at some of the federal levels. That's creating some people that are coming to our site. So it's a very fluid place right now, I think, in the health workforce space. It's always going to be hard to find physicians, especially for smaller communities, but the flow seems to be pretty good. It's the other things that are kind of going up and down. The pipeline can really shift quickly.
Yeah. Several points there along really, describing the landscape for rural recruitment. Do you happen to see potentially different staffing models where maybe it is more medical assistants or nursing assistants or more support staff? You mentioned earlier, nurse practitioners where they are standalone and kind of operate exclusively from other relationships. Do you see more of that in terms of workforce in a role where we talked about people wearing many hats? Do you see that change in terms of the clinician environment?
I think it has to and has been for a number of years, because again, you're just not, especially when you're talking about a nurse practitioner or a physician assistant, they're going to be the lead provider in probably a lot of communities, especially smaller communities. And around that, you have to build a team of what's available to you. So that flexibility, which rural has always been good at, is going to be even more critically important, because you're just not going to have the physician supply. It's already, like I said, it's always been tough. It's not going to get necessarily better. Now we are creating some rural residency programs that are helping get a few more people out there, which is wonderful, but it's still just going to be adding a little bit to the pot. And again, every little bit helps, but I do think that you're going to have to be creative with your staffing and how you look at what roles can cover what needs that you have in that clinic. So those that can be more flexible and more adaptable, I think are going to be the ones that really do better in this environment.
I think we're all waiting. I know we did have new slots approved, residency slots approved, and then the additional funding to go behind that, specifically to drive training programs for those rural training tracks. And I know I've had high success rates with folks who go through those programs within their residency of choosing to stay in those areas. But I think until we get more slots and more actionable pieces to kind of fill those gaps for the physicians, a lot of the activity will then fall on those APPs, like you mentioned.
Yeah, I think again, one of the most exciting things is going on is the expansion of rural residency. That has been very exciting. The RRPD program and the teaching health center programs, both of which we're very familiar with, are exciting, and they have added new physicians into the workforce from them. And I think that there's a high probability a lot of them will stay at least working in safety net facilities, if not rural communities. And certainly that's very exciting and needed. It's just that we were so far behind. It sometimes gets discouraging. You're like, okay, I'm not sure if we're making any impact, but I do think in certain areas that, especially these residency programs are set up, there's a good chance that the residents will stay in those areas. And that's helpful. I think you'll see some flare-ups of places that are really starting to look pretty good, but it's still a challenge. People will tell you there's also a distribution problem, and I don't disagree with that either. I think that we still have a hard time moving folks from where they train, especially whether they came from a rural area or not. When they're training in a bigger community, it is harder to get them into more rural places. So we have to continue to hammer away at what are the benefits and looking at some of the admissions practices into those programs and really try to look at what's successful.
Yeah, and I think that we've touched on several barriers. I think nobody's shying away from the word shortage across any workforce or any industry, but what would be some of the key pieces to retaining those providers and clinicians in those rural areas? And then how can organizations overcome some of those pieces where no, you don't have maybe some name brand stores or other things. What advice would you give to folks that are in those areas looking to retain and then also provide a solution on overcoming some of those barriers?
It's interesting. This is something that you talk about, some of the principles of 3RNet. One of them that I think has evolved over the many years of our association with Dr. Don Pathman at the University of North Carolina in what we call our PRISM program, which is a data source. Retention and recruitment factors are often different. So how you recruit somebody to your community or to your hospital or your clinic is oftentimes one set of determinants and factors in what you do to make your community approachable. You look at the contract, you look at a lot of the external factors. There's a lot of things you look at in the recruitment process. Retention does shift your hat to a different place. What are we looking at for retention? Because somebody could come for one reason, but as their kids grow or their family changes, their situation may change. So what was important to them when they came to your community may not be as important, and that may have shifted. Therefore, your communication with them is always number one. You've got to continue that open line of communication with anybody that works for you. Has their situation changed? They came here maybe 1, 5, 10 years ago, and now their life situation looks different. Maybe they have parents in a different state that they have to go home to take care of. Or maybe there's other issues that they're trying to deal with there locally. They'd love to stay in your community, but maybe they need more of something that could work out. Daycare is often a problem. Housing is often a problem. So you have to take their entire life and kind of see where can we help them balance it if it's out of balance, and make sure that that is a retention type of activity. And everybody's going to be just a little bit different on that. There's common retention practices out there. I won't go into all those, but there's things out there that I think that everybody knows that are good retention models, good benefits, some nice things, some encouraging things to help people stay. Everybody appreciates that. Compensation is certainly one of them, but it's really about how are you treating me and how am I being treated from the very top? Do I have a relationship with the person in charge of this organization where they actually know my family and know what I'm doing, and maybe that my life situation is changing? So retention is a lot of work, but it is just mainly maintaining that relationship. You recruited them hard. You oftentimes, especially when you're talking about physicians, you recruited them hard, possibly for years. And then when they got in the door, did you recruit them just as hard to keep them? When I was doing a lot more presentations, I'd ask, what is your retention budget? And I would get blank stares. What do you mean? What is our retention budget? You have a recruiting budget, sometimes in the thousands and thousands of dollars to recruit somebody. How much are you spending to keep them? And that is not always thought of, especially when you're talking about, again, I think that larger places that have more resources, more in-house recruiters, a little bit more sophistication to their processes because they can spread it out across more people, they think of things like that. When you're in a small place and maybe you're a standalone critical access hospital without any other support, nobody's ever told you that. Maybe you're just using an outside recruiting firm for your new people. And then kind of once they get in, yeah, you have a picnic once a year and that kind of thing, which is wonderful. But you don't ever really spend a lot more time about how am I going to keep this person I just spent all that money bringing in. And they end up getting frustrated and leaving because maybe there were some things that were obvious that you missed that could have kept them.
Another piece, really be transparent about the makeup of the community. And if they're a surgeon or a proceduralist, be honest about the volumes and then the opportunity to grow. That's where I've seen you've spent a lot of time recruiting a general surgeon that's much needed in a community. But if they don't have the support staff, anesthesia coverage, the tools that they need, and then the opportunity to go find the business, because they want to keep their skills set up as well. It's not just busy to make work RVUs. They want to make sure that their skills stay strong. And I think, having a good relationship where you're able to, as a recruiter, to have that information when you're talking to candidates to build some of that going in, it helps educate them when they do come on site that they have the right questions to be asking of maybe the clinicians that are already there, but also the administration.
Yeah, it's all about building trust right off the bat. As soon as you start recruiting somebody, you're building up a trusting relationship, and you want to maintain that through the life of their work with you. And it should be very much back and forth, just like any kind of relationship you'd want to have with somebody is, hey, again, our situation changed. Maybe we recruited you when we were doing this. What if we were undertaking a new hospital building project and for some reason or another, the funding fell through? And now we have to re-look at, can we keep you here and how are we going to do that? We want to, but how do we do that? And you have to be very open with them to have that conversation. It's like, well, we could do this or this or this. So there's no one answer. And that's where the art of this comes in, right? It's like you can go about the science of trying to find the leads, but it's all about art and trying to talk to somebody and just build that trusting relationship.
Do you want to know when to do what in your job search? First Practice, PracticeLink's resident and fellow career guide, teaches you 10 easy-to-follow steps every prospective physician needs to find their dream practice. And best of all, it's completely free at firstpractice.com. Becoming a physician is hard. Finding a job doesn't have to be. Thank you for listening. Now we'll return to the podcast.
You mentioned the work with UNC and the PRISM data warehouse. So tell us a little bit about that and how 3RNet is using the technology and data to maybe innovate in the recruitment space or provide folks with additional reporting and metrics.
Yeah, I think there's a couple different things we're doing. First of all, that is a newer product for us. That PRISM has been around since 2013, and it is basically a retention system that does automatic surveying to National Health Service Corps loan and scholar recipients, as well as state loan and scholar recipient programs. We currently have 36 states that are a member of PRISM, and these surveys have been going out since 2013. So we have a lot of data that has been gathered over these years, again, mostly asking retention questions as they're getting their loan repayment paid off. And UNC directs our efforts with this. Don Pathman has been doing research and retention since the 1990s. So we have a really strong relationship with the Sheps Center at the UNC. That's who our partner is. And we very much appreciate trying to now incorporate more of the findings from those data points over the years and inform and use that data for employers to make even better decisions on retention. Okay. It's always going to be a work in process. We are not just flush with funding. It is able to pay for itself, but we are very appreciative of where we've come with that. I do think that also on our website, our job board, which is what a lot of people know us for, we've put a lot more tools out there, especially thinking in minds of that smaller employer, tracking that we've used in it. We can now track candidates. We try to keep up as best as we can with other job boards that are, commercially available in the market. Obviously, PracticeLink has been a great partner and a great inspiration to us. I think that a lot of the work that Ken and this team has done over the years has always kind of inspired us, just working from a nonprofit angle behind, and also, again, a little broader focus. Since we're not just looking at physicians and APs, we're looking across the entire spectrum of healthcare professionals. So whatever we can do to bring technology in at the price we can afford is what we're going to do. And we've done a lot of upgrades over the years. If you were to look at what 3RNet looked like in 2012 or even back in 2005, it doesn't look anything like that. Again, you can now track candidates. You can do a lot of different things in there that are very helpful, automatic referrals and things like this that are really helpful for the growth of the products. I kid people when I say that we'd like to be the Indeed of rural health, but we don't have billions of dollars to do that. So we do our nonprofit version of Indeed, but I do think that we have a very and have earned a very trusted space with the people that post jobs on our site. We have that grassroots effort. And I do think as we go forward, we'll continue to try to incorporate technology as it becomes affordable and something that we can put into what we do. An example is AI. AI is something that we're going to be looking at, as everybody is, over the next few years. How does that fit into what we do? How would that make the work easier? When you talk about what does AI do, it can make a little smaller place perform bigger. And we're going to have to bring that to them over the next few years. And so we are definitely going to be looking at that. And again, I appreciate partners like yourselves that are kind of leading in that as well, so they can help direct us, saying, this is something that possibly we should be doing as well. So we're looking forward to that. PRISM is a part of that as well. Again, that data piece has certainly been something that we've enjoyed having. We just took over the program 3 years ago, even though it's been around since 2013.
What training or additional educational resources does 3RNet provide to maybe new recruiters or recruiters in a rural setting, maybe even beyond that, where it's an administrator or sometimes it's the COO or something in a rural market? But what additional training pieces does 3RNet offer for those folks?
We've always done what we call education. Some people will call training, but basically we have a process that has been developed over the last 25 years, early into 2000s. A lot of our organizational members got together and kind of put together a training manual, how to do recruiting. And you've seen maybe some other organizations that have done this. I think AAPPR has had one for a long time, but that isn't always as accessible. So we started putting together kind of a multi-part training manual over the many years. And with that, we've done educational outreach with those and presentations at different webinars and across the country. I think the biggest thing we started about 8 or 9 years ago would be the Academy. The 3RNet Academy was probably the most visible piece we put together. It's a 6-part webinar series that is directly aimed at the employer, especially an employer that maybe is with a safety net facility and doesn't have a whole lot of resources, but we can give them a lot of resources to get themselves started and set up, and really looking at all these kind of issues. And how to form a team is one of the biggest pieces of that. I think that's step 3 in our process, is how to form your team. And it walks you all the way through retention with a lot of resources out there publicly available. Again, these are not expensive resources, but I think that education or training is an opportunity to kind of scale what is out there to them. And that's always been our direction. So I think that has been probably one of the most well-received pieces that we've done over the last few years, probably one of the most visible. A lot of our states actually sponsor all the facilities in their state. So what they'll do is they'll give us one fee, and then they will let folks come in for free on that. So I would say if you're a facility out there, check with your state organizational member if they are sponsoring the Academy. We will start it up again. It runs in the fall, October, November, and into December. And we're very much looking to bringing that to everybody again. And again, it's been a very, very successful, especially to somebody that if you're trying to set up a department or trying to expand a department or trying to do maybe just a little bit better job of what you've been doing and you're trying to get new ideas, that's a great place to do it.
So virtual training.
Virtual training, yes. We have done on-site things before. Another thing that we've done is what we call an assessment, where a community will ask us to kind of assess what they're doing, and especially their visible online presence when it comes to recruiting. So we can do that with staff that will go in and look at their website, go in and look at, even applying for a job. It's amazing how poor that looks for a lot of facilities. It's very complicated. Heck, we still have people asking for a fax. And so some of these websites have not been updated. The community doesn't look like it's been, like the Chamber of Commerce hasn't done anything in a while. So we just try to give a quick assessment. It's like, here's some things you may want to do just to make yourself even more approachable. Because if a candidate doesn't know your town, 99% of the time, the first thing they're going to do is Google it. And they're going to find these resources. So you better look as best you can in that, and also make everything easy to apply or to find you. There has to be a point person, and hey, they have to be easy to get a hold of and responsive. Response rates, when I first started recruiting, 72 hours, maybe 48 hours was good turnaround. Now, Christy, you've done this for a long time. If you don't get back to somebody within 24 hours, it's almost like you lost their attention. And sometimes it's even quicker than that. So that response rate is something we always preach. And it is probably one of the biggest challenges, again, in a small place. Depending if your CEO is your main person that's going to be calling somebody back, it's like that is a horrible thing to do. You need to have somebody in between that can at least get an email back, at least get a text back or something to say, hey, we hear you, we saw your application or resume or whatever, and we're going to get back to you. So that's an extremely important thing.
Good point there on, it's an email, it's a text, it's a phone call. That outreach is really, really important.
You just got to be acknowledged quickly, and then you can go from there. But that first response has got to be quick.
We kind of got to this a little bit earlier with practitioners practicing at their top of their license, really to serve these rural communities. Are there other tools, and I'm thinking about tele-ICU, which is pretty common, tele-psych programs, but are there any other tools in terms of patient care that can really make a meaningful difference in a rural setting?
It's interesting. I'll tell you that I am not the expert on that. I do know that telehealth has been such an important part, especially over the last few years after COVID. And the expansion of that has been front and center in everybody's mind. The telemonitoring as well that goes along with telehealth. So it's not only the appointment, it's just monitoring somebody. The expansion of broadband is really probably the most critical thing in most states to make that available. So the tools are all out there. It's can we get them to the right place? Seems to be kind of the biggest question. So I don't know of, as far as emerging technology, that what may be out there and kind of be on the horizon. I think it's more getting what is currently available, consistently available to these places that are a little bit more remote and maybe further away from broadband access. Because I think there's some really, like you mentioned several exciting tools, telepsych, telehealth, the ICU. There's all kinds of potential out there. It's just consistently being able to get it there, especially there's been a lot of grant money, especially in the last few years, that have been into that. So I would probably stop there to say, yeah, I think the tools are there. There's a lot of exciting things to be done. It's, again, getting them access into all the communities that need them as opposed to ones that are just going to be on a broadband link.
And I think during COVID and after, there have been a lot of initiatives to expand broadband. And most people, think, oh yeah, everybody has a cell phone and then they have Wi-Fi in their house. And we found out rather quickly, at least if you had school-age children, during COVID, no, not everybody has internet in their house. Or I think more importantly, in a rural setting in those sizes of towns that you're serving, is it available? Is it available and is it fast enough to be able to handle some of these pieces?
Yeah, it's not only the access, then it's the affordability. We all think that, we can afford $80 to $100 a month or whatever for internet access. And when you're living on a very stretched budget of, maybe you're making $30,000 a year and trying to support a family on that, $100 a month is not going to happen very easily, if at all. So you have to kind of take that into account as well. I mean, we're dealing with a lot of not only the rural, there's a lot of financial barriers as well. So getting the broadband there is great and much needed, and certainly what has been focused on here recently, but also it's the cost of it or the ease of accessing it. Is there a centralized community place where people could go to access it in a community, especially talking about a community of 500 people and maybe an hour from, anywhere that's close? That's a lot harder to deal with. So simply saying, hey, yeah, they can just use telehealth sounds great. But it's like, well, the realities of that are it could be totally unaffordable, or it's very, very slow, and it doesn't make that communication or this kind of appointment available. So we still got a lot of work to do in that area for sure.
And I'm thinking some places they're still processing paper applications, knowing that potentially their staff or those job prospects, they may not have a home computer and Wi-Fi. They may be filling that out at the library or somewhere where they have that access. So yeah, those are good points. And they may be checking their Yahoo or their Gmail. They may be checking those things every day, where all talent acquisition and HR leaders need to take a step and think about that in some of these communities.
It's just like anything else. I think when you try to deal with an individual community, you have to look at all of these infrastructure issues before you can make a full assessment of what's available to them or not. And now it's going to get even more challenged. For what we're talking about at the federal level, if there's going to be Medicaid cuts and things like this that are being proposed, it's going to get even more challenging. It doesn't mean it can't be done, but everybody's going to continue to be creative to figure out new ways to get the care that's needed out to the communities that need it.
Let's talk a little bit about policy advocacy and what type of work does 3RNet do in supporting the advocacy that's needed for rural healthcare workforce, potentially working with NRHA or other programs that you guys might partner with for that?
3RNet has always considered ourselves kind of very much a grassroots effort, definitely educational, right? Advocacy, some people think of advocacy of going directly to DC or to your state office or to your state capital to kind of promote or basically lobby. And we've never really had that presence in 3RNet. However, again, we are very good about bringing the field, the grassroots, back to the people that do move those things back toward policy. So NRHA has always been one of the biggest ones. As you're right, they have a very big DC presence. Even NOSOR, the National Organization of State Offices of Rural Health, again, as a key partner of ours, they do some work like that. They have contacts in DC. And they are also, because we are affiliated with them so closely, they're also listening closely to policy opportunities available. There are other partners out there like the National Association of Community Health Centers, which is NAC, Association of Clinicians on Underserved, which is ACU, NAO, which is the National AHEC organization. All of them have certainly voices through different ways to policy, especially at the state level, and then a lot of them at the federal level as well. So we've never really maintained like a lobby or any partnership in a DC firm because we have all these other contacts, but a lot of them ask us about what are we seeing, especially at the state level, because at our academy, we might have 700 or 800 small facilities that are participating in that. And we can tell them this is what we're hearing from them. While we're thinking this is a bigger issue, it's like, well, maybe that's not the bigger issue at all. The real issue is more this. So I think that we try to advocate by listening and moving along those conversations to those that do move along to, the policymakers.
Are there any key opportunities identified from your last academy section, so fall of 24, maybe?
The talk is still more on retention than it was on recruitment. I think that is still what we are hearing more is that post-COVID, everybody was hiring very slowly back to capacity. It's more about trying to hang on to the staff that you have. So retention seemed to be more of the questions that we were getting as opposed to recruiting. That could be very specific too. There are certain states where, like we talked about, there's hotspots where, hey, we can't find a lab tech, to save our souls because it's just really hard. There's not a lot of training programs in our state. But I do think that we have seen more questions on the retention side than on the recruitment for a little while. And I don't know if that's going to change here again with the way things are going to be in the next year or two. It seems like we're going to have more candidates because there's so much movement right now, whether intentional or unintentional. There's going to be more movement of health professionals, I feel. And this is across everything. I'm not just talking physicians. This is across the whole gamut. But getting them new opportunities in places that are much needed is still going to be a challenge. Just because they may have lost a job in, a big market doesn't mean they're going to necessarily try to move to a small community to get the same job. We're going to still have to work just as hard to get them to consider something outside of maybe where they were. So I'm thinking especially of scientists and maybe clinicians that were attached to these big federal programs like a CDC or an FDA or something like that may now find themselves in the job market. How do we reach out to them to make sure they understand that these are opportunities for them? So there's still going to be certainly the challenges of that, but I think overall still people see the benefit of retaining your own staff seems to be a best practice as opposed to trying to always recruit.
For sure. And I think that you mentioned earlier the retention budget, which isn't there, but I think the revenue losses are definitely a number that most CFOs or hospital and clinic leadership can put a finger on pretty quickly.
I've said for years that the human resources function is really probably the bigger issue at a lot of these facilities because recruitment and retention are mostly a subset of all of the human resources, that HR. And oftentimes that is a totally unfunded or underfunded endeavor. Maybe you'll throw some money at recruiting somebody new, but sometimes that department is one person or one and a half. Somebody's doing payroll. And I just think it's a critical place that every CEO, every leader needs to spend some time with, because if that is your most valuable resource, and let's face it, in healthcare, it really pretty much is, how can you understaff how you treat your folks and how you are paying attention to bringing new people in and training them and keeping them? So there have been a lot of great strides I've seen going across the country and just looking. There's a lot of places to do this very well. Small places that still do it very well, but it's because they pay attention to it. They really have to focus on it. It's just as important as any other measure you're tracking at a hospital or a clinic. So to invest in that piece, I think, is extremely important, and I'm trying to get that word out there for years.
Yeah, definitely. The times when I've served rural markets, I love rounding through the hospital with the leaders. And you can tell leaders who've really taken that time and that investment to do, rounding with me as somebody visiting that day was not just a once a year occurrence. They did this daily or at least multiple times a week because they knew the staff's name, they knew their kids. So much of the things you talked about, they reached out and made those connections. And then equally, I feel like they had some transparent communication. One of the best events I went to was taking a specialist out. So he was just going to be visiting like maybe 2 days a month doing clinic in this outreach location, but much needed. This was a 2-year recruit. I mean, it took a long time to get this clinician to our main market and then sending him out, but taking him out, and it happened to be like an employee grill day. And so this was a very agriculture community in Eastern Colorado, and steaks, that was what was on the menu. I mean, everybody got a fairly large steak because the beef was just everywhere. I think if they could have put cheese on it, that was their other big agriculture industry. But it was a pretty cool thing to get to see. And those leaders were genuinely ingrained and made just a great impact in their facility and beyond the walls of the hospital and clinics within the greater community.
Yeah, I mean, let's face it, the most important recruiter is the person at the top because they set the tone. If they're deeply invested and make it a priority, everybody makes it a priority. If they don't, it can't become priority. And I understand, I think being a hospital or a clinic administrator is probably one of the hardest jobs in the world because you have so many competing priorities, including just the reimbursement, trying to keep the doors open. But you can't keep the doors open if you don't keep the people. So I think it has to be right there with your top 2 or 3 priorities as any kind of leader. And unfortunately, I don't know if it's always there. I think it's becoming more like that. It's becoming more and more aware that it's killing you if you're having a lot of turnover, a lot of staff problems. So you have to make it as such. But that's a long-term investment too. It's kind of like growing your own or having a pipeline program. It takes years. That doesn't come overnight. You're rounding for years. So you have to do that culturally throughout the whole process. And if you don't have it, you have to start it and kind of build it over time. But it's going to pay dividends in the long run. Again, the places that are most successful with both recruitment and retention that I've ever seen are always start at the top. Very dedicated, very involved leadership. And that trickles down into the entire organization.
Those are definitely soft skills that you aren't learning in your business school or your MBA program, even your MHA program. I think if you were an administrative resident or spent some time in a facility with great leaders, that's where you learn those things. But these are definitely soft skills.
The 9 years I worked at a hospital, there was different efforts to do rounding and things like that I thought were not always the most sincere. I think especially in smaller places, you can smell BS. It's like, it's got to be authentic. It's got to be real. It's like, you've got to care about me, and you can't just come out and say you care about me. You've really got to be able to care about me. And that's a challenge. I mean, that means it's got to be a priority, and you have to really work at it. And it maybe a team of people do. But I do think that the most success comes in places that are able to do this in very small places. It's because they really care about each other. It is just like the towns that are successful. We know that. I mean, if the organization is not successful, a lot of times the town is not successful. And towns that struggle have the same issue. There's some kind of maybe fundamental issues that are really a problem, especially if you've had like economic challenges or a big loss of a facility, like a big company has moved out. That leaves huge holes. So that's why every community is so different. You kind of have to take an assessment of what all you're facing and what all your assets are and try to apply them to the same direction of recruitment and retention.
Yeah, and I think the hospitals and clinics end up being a little mini city, even in a large market like LA or San Francisco. The hospital has its own kind of ecosystem that is evolving there. I think in these small towns, they're often the largest employer. Maybe it's the school system or government entities, but then the hospitals end up being the leading employer. You mentioned those grow your own programs, and I 100% agree. I mean, anytime you can align and try to do that, but it is a long-range strategy. It isn't something that's going to produce results overnight. So you have to be in it for that, knowing it's going to take a little while.
Yeah, you have to have commitment to it, and sometimes over multiple leadership changes. And that's where I think maybe some of the biggest challenges is, one person brings it in and had it going, and then you have a leadership change, and it just kind of gets pushed to the wayside and lost. And so there has to be a commitment kind of at the organizational level, maybe even at the board level, because the board members most likely are going to survive those leadership changes, and they've got to have that commitment to it. It's like, hey, we're going to always be consistently trying to grow our own, and especially for these key health professions that maybe are really driving what we do. But it's a short-sighted world, right? We live in a more immediate gratification world. And when you say you're going to be developing somebody over 10 years, that just sounds like a lifetime. But the organizations that can do it and pull that off successfully are the ones that I think that will survive this and have survived this.
So let's talk a little bit about your legacy at 3RNet. Is there a story that you have that reflects, the real impact of 3RNet's mission in action? Probably more than one story, but you got a story for us?
There are so many people that come back and say, it's interesting because 3RNet is both very visible and not as visible in a state, because a lot of our state organizational members are underneath a different name, like a state office of rural health or something like that. So people will say they found their job through a website, and not necessarily even remember who we are. At the same time, probably some of my favorite stories are just more almost on the employer side of the impact that maybe some of our training or some of the encouragement they've gotten from us or some of the resources they've gotten from us that really made a difference. We hear that a lot now from the academy. People come back year to year to the academy, and it's like we love coming back to that because it just feels refreshing. We try to have a real conversation with them every year about the trends, the topics, but always remembering this is still a process. And one of the other places I hear a lot of success stories is we go to the AAFP meeting, the American Academy of Family Physicians meeting, the student resident conference every year in Kansas City. I've gone there for years, and it's always refreshing to run into residents that maybe had met us one year, and they'll come back a couple of years later as staff at a hospital or something like that, or they're now working for a residency, and they will remember 3RNet and understand and call us the good guys of recruiting and retention, because that's what we've always kind of put ourselves out there as. And I think that those are the kinds of activities that make us feel good. It's interesting. It's hard to get those responses. I wish that we had even more opportunity to kind of hear those stories. I think that people move on so quickly. Something happens and there's a placement and people kind of move on. But our legacy is still more about building that grassroots group that then can make an impact state by state, community by community. And I think the work is very important. I mean, as far as I know, we're still one of the very few nonprofits in this space, especially somebody running a job board as large as ours in this time frame. So I think we take great pride in that. And I think we take great pride in trying to be there for communities that really either have fallen through the cracks or is just tough maybe to recruit to. And we give them some encouragement and some ideas and some best practices and just try to be their advocate for processes. So those are probably success stories that I probably have the most. I wish I had one for sure that I could tell you, Christy, but I have many, I guess maybe we'll go with.
I'm glad to hear that. As somebody who spent a lot of time in small towns in Oklahoma, definitely support the work that 3RNet is doing. And I will give a plug for the AAFP National Conference. That is hands down favorite conference to go to every year, I think, because they've consistently held it in Kansas City and you get to know Kansas City there. But the people that go to that really make a difference. The program coordinators, directors, and those residents and medical students, everybody is just really excited and aligned from a primary care standpoint of improving health outcomes. So it is one of the best specialty conferences that I've ever gone to. So as we wrap up, I want to get a little hopes and vision for the future of rural healthcare and maybe what can we do today, either as recruiters or administrators, to really help build that vision?
I think we've always had the tools and know where we should be going. It's a matter of consistently maintaining the progress. So as we just talked about, everybody knows or seems to know in the workforce space that we have deficits in certain areas and certain professions. And there are some different tools that work for that, whether it's residency training or perhaps an AHEC program or some other pipeline program. So there's lots of tools out there that can be utilized. I think it's trying to keep those on the forefront of everybody's mind as you're going through policy, especially policymakers, right? Because they tend to want quick fixes. And it's not a quick fix. It's a long-term investment. It's not unlike roads. You've got to have roads that work to get things moving. And when you don't pay attention to them, they do fall apart. And so it's an infrastructure thing. And the infrastructure of workforce and healthcare is so interrelated. And I don't know if it's always been thought of that way. I do think that possibly post-COVID, they're seeing it even more. They meaning policymakers, and certainly it's been brought to the forefront. I do worry. I don't know what the environment's going to bring the next few years, but I do think our voice has to be just as loud as it ever was, that inattention to something just tends to cause further breakdowns. So we know that there are issues. We know that we have some tools that out there that are working, but they're going to have to be invested in long term, and they will produce results over time. So how do we continue to advocate or get the message out there that the tools that are out there can work? Even with a little bit more investment, they may work even better, but certainly cutting them back could cause a critical failure in the process. If you're not careful, the unintended consequences of some of this could be disastrous. And that's where the debate right now going on with cutbacks with either rural funding programs or possibly Medicaid or anything else. Those are going to have direct impacts downstream. And when it comes to prioritizing trying to keep a hospital open with reimbursement versus a pipeline program, I fear that's going to be really hard to kind of raise up to that level. So my vision is I do believe there's a lot of things we can be doing, and there's a lot of things that are already in play that are working. It's trying to keep them funded, trying to keep them moving forward, expanded possibly, and just committed to, because I think that you don't always have to invent a new tool. You just have to leverage the tool you have maybe better.
That's great. I appreciate that insight and agree with you wholeheartedly. So on behalf of PracticeLink, I want to thank Mike Shimmens for appearing on the Workforce Wisdom podcast. For more insights on rural healthcare recruitment and valuable resources from strategic partners like 3RNet, visit the PracticeLink Resource Center on our website at practicelink.com. You can also email us at plmedia@practicelink.com. My name is Christy Bray. Thank you for listening to Workforce Wisdom.